The next two assessments we're going to combine, and that's the Gillets and palpation of the Iliolumbar ligament. The reason why we combine this is because Gillett, we're not using this as an assessment for the SIJ. We're looking at the forces that act through the lumbar spine, through to the sacrum, through to the ilium via the sacroiliac joint, and down to the hip. Okay, and we're looking at how optimally the body is performing that force transfer. And we know if that's not happening correctly, that it starts to put some of the soft tissue at risk. And one of the main structures that is at risk if we see a positive Gillets is the Iliolumbar ligament. What we're looking for is the forces that are acting down the body from gravity, pushing on the body weight, and also the ground hitting the body and the ground forces acting up that way, and they converge around that SIJ. And the Iliolumbar ligament sort of runs along the iliac crest into the transverse process of L5 and L4, okay? And the fibres run crossways across those forces going up and down the body, okay? And so that Iliolumbar ligament is in quite a vulnerable position across there. We're assessing right side versus left side, and we're looking for symmetry of movement. So you palpate the right PSIS with your right thumb, and you're palpating the S2 with your left thumb. Okay, and then you ask the patient on the ipsilateral side to flex the hip to 90 degrees. And as you can see, the thumb moves nicely downwards. You're looking at amplitude of motion, and you're actually looking at the quality of motion. Okay, so that's moving how we want it to be moving. Okay, and then you compare the left side. So same thing, and you can see the PSIS on the left hand side is moving downwards in the same way the right side is. So that's a symmetrical movement, right versus left. So that's a negative Gillett. The positive Gillett comes from the glutes not activating in time, not feed forward. And so when the hip comes up, the glutes need to activate to pull the ilium backwards. In a positive Gillett, the glute isn't doing that. So when the hip comes up, it's not firing off, and the ilium is pulled forwards as opposed to backwards. Similar thing with the external obliques. As the hip comes up, the external obliques need to posteriorly rotate the ilium. And again, if they're not feed forwarding and doing that, then again, you can get a pull anteriorly of that ilium. The Iliolumbar ligament, it's classed as an anterior ligament because it sits on the anterior aspect of the iliac spine. It attaches to the L4 transverse process, L5 transverse process, and it attaches down into the sacrum. So it attaches onto 4 separate bones. So it's a very busy ligament. And as we've said, we've got all those forces going up and down the body. Like in the Gillets, where the pelvis is pulled forwards because the glutes, the obliques aren't keeping the ilium back. So actually it rocks forwards. What happens is the position of that Iliolumbar ligament changes as it's moving through your normal everyday movements, and any change, any deviation from that ligament is going to put excessive force through the actual ligament. If any swelling happens in and around that area, any inflammation, any scarring, you get also fatty deposits start forming on that Iliolumbar ligament. If you imagine the innominate coming forwards in flexion, it can close this gap between there, and any swelling, actually you can end up with an impingement happening between the L5 transverse process and the iliac crest, or the sacrum and the iliac crest, and the patient will often feel that as a jolt or a tweak of pain. An easy way of locating the Iliolumbar ligament is you come to the dimples that we find on the lumbar spine, and if you just feel just superior to those dimples, you can feel the posterior aspect of the iliac crest, and you just sort of push into there, and you can feel sort of the thickened, soft feel of the ligament. It's actually an anterior lumbopelvic ligament, but you can get to it coming from the posterior aspect quite easily. Okay, it then travels about 4 centimeters up the iliac crest, and then goes over to the transverse process of the L4, okay, and also to the transverse process of L5. From the dimple to the transverse process of the L4, there's about 4 centimeters where that iliolumbar ligament is on its own and it's unprotected by any other structure. So with all the forces coming up and down the body, it's in quite a vulnerable position because all the fibers run this way, whereas all the forces run that way. But easy to palpate. And it's a good assessment tool because very often you can palpate into around that area, and the patient very often says, that's exactly my pain. The Pelvipro has never failed to correct a positive Gillets test. So the handle on top is pushing down on the ASIS. Okay, the base is posteriorly rotating the whole pelvis. Okay, so as the leg comes up, okay, we come to 90 degrees. So as Claire then starts to extend the leg in a posteriorly rotated position, she's activating those glutes in that posteriorly rotated position, okay? And all the way through the extension, the pelvis wants to come forwards, but on this side, it's held in a posterior rotated position, activating the glutes and the external obliques, still held in that position.